Good morning, everyone. For our next session, Dapacare, I would like to invite Dr.Pramila Kalra, Bangalore-based diabetic endocrinologist currently working as an associate professor at Department of Endocrinology and Metabolism at MS Ramaiah Medical College and consultant at MS Ramaiah Memorial Hospital. Dr. Kalra is passionate about teaching and she is also involved in research involving thyroid disorders and PCOD. A member and advisory board of Indian Journal of Endocrinology and Metabolism, executive committee member of KRSSDI 2012, scientific committee member of MS Ramaiah Medical College and Hospital, graduate with honors in many fields, and she is the Kumari Lal Gold Medal for Best Work in the Department of Medicine, a second prize in poster presentation in pharmacology. I welcome you, ma'am. Welcome to Precision.
Yeah, just to think that I'm now professor and head. This associate professor, I think they've got a 10 years old CV, I think. So no problem, it doesn't matter. So the thing is that the topic for today's discussion is Dapacare. That is, we are discussing about the comprehensive outlook of the dapagliflozin, which is a SGLT2 inhibitor, clinical data, and what is its relevance to clinical practice. Now, if you see that dapagliflozin has been in use for quite some time now, and we have been using it for many years. Initially, we started using it as an anti-diabetic medication, but over a period of time, we came to know the benefits of the SGLT2 inhibitors in the form of the cardiac and the renal benefits. And then we came to know multiple pleiotropic benefits apart from the cardiac renal, like a good effect on the uric acid and multiple other benefits. So this is how the cardio-renal metabolic spectrum has come up over a period of time. Can we have a pointer or something? So when we talk about the cardio-renal spectrum of the SGLT2 inhibitors, we know that we started off with the EMPA trials, the EMPA-REG, and then we came to know, oh, this is also happening, because when initially the data of empagliflozin came, we were like, okay, is this the thing? Is it actually happening? Then more and more data came up, and we actually found out that yes, these drugs are very good and they have good effect on the cardiac and the renal outcome. And we know there are multiple trials which came after that. And if you see the trials with the dapagliflozin, we have the DAPA-HF, we have the DAPA-CKD, we also have the DELIVER. So we know that there are multiple trials which came up. Now, if you see the data with dapagliflozin, we know that if you see the initial studies or the initial data, we only were thinking that these drugs will be beneficial only for patients with high cardiovascular risk. But over a period of time, we came to know from the other trials, including the trials with dapagliflozin, that it was just not beneficial in high-risk group, it was also beneficial in our patients with type 2 diabetes who are overweight or obese, or who are even not overweight or obese but may not have many risk factors at the moment, but over a period of time these drugs may give them some beneficial effect. So we came to know, yeah, even if the patient has some risk factors, even then this drug should be offered to that patient and it may benefit the patient in the long run. And we know that prevention is always the best approach. As we were discussing in the previous speaker's talk also, that many of the patients are not even aware of their renal things, they're not aware of the fundus examination to be done, so they don't even know that the complications can develop. So it's a very important thing that as doctors, it's our responsibility to see that these things are taken care of and the drugs which have good or beneficial effect on these organs or have some preventive effect are given to the patient. And then we all say that, okay, once these things have happened, then we call it as a therapeutic window. And where we have the cardio-renal event which has happened, or patient has repeated events or heart failure, and then the question of treating that event comes in. Data available with dapagliflozin, lots of publications and data, as I told you, starting from the initial DECLARE trial to the DAPA-CKD to the DAPA-HF. So we have lots of data coming up, and we know that it has been shown that it is beneficial even in the normal type 2 diabetes patient who comes to us, where we think it as an anti-diabetic drug for sure, but we also get the other pleiotropic benefits, including the cardio-renal benefit. So what is this Dapacare? It's actually a sort of extensive program which is designed to investigate the potential of the CV and the renal effects of dapagliflozin in patients with or without type 2, because we also know that it is also approved as a solo drug as an indication for heart failure and for CKD as well. So if you see, we are all aware of the DECLARE TB which came in the beginning, where it was a CV outcome trial where they had around 17,000 patients. Then we had the Dapacare, where there was it was a renal outcome trial, and then we had the Dapacare, from where we know that the approval for the heart failure indication came in even without diabetes. And then again there was DELIVER, where was the HF-CV outcome trial, where they had around nearly 6,263 patients, and also patients with preserved ejection fraction with or without diabetes. And then we also know there were dedicated trials in MI patients and patients who had either preserved ejection fraction or reduced ejection fraction. So we know that when we talk about the studies, we have multiple CV studies starting with the CV outcome trials, with the heart failure outcome trials, and the preserved ejection fraction also, and also the patients. We also have data with the renal studies as well, including we know the DELIGHT and the Dapacare, where in DELIGHT we had patients with type 2 diabetes and CKD, and the Dapacare was again a CKD outcome trial. So we know that why these studies are being done. So we are trying to see the sub-indications and specific patient types, like, okay, is this patient going to get benefited? Okay, if a patient between 30 to 60 got benefited initially, then the thought process came, should we try it in lower eGFR? Will it be working? Then they said, okay, let us go down to 25. Then they went down to 20, and now we know now there is data with hemodialysis as well. So this is how the things have built up over a period of time, with more and more information and the data on the benefit coming in, the indications are expanding. So we know that we have data now in multiple renal indications as well with this drug. And also we know that for even in these drugs now are being tried for other indications, which I just talk about a little bit, including the MASLD, PCOS, and those indications are also there now, and even in patients with OSA. Like if you see the patients who come to us with OSA for obesity, we have very few options available for those patients. So these are also one of the things which are being tried at the moment. So if you see, we know that if you initiate the treatment early, we know that the nephroprotective effect is better, and it improves the nephroprotective action, and we have this data that early onset of treatment actually improves the nephroprotective effect of dapagliflozin. And also if you see the patients under routine care, which we say this is a normal type of a type 2 who may not have the high risk factors, who may not have had an event, but this patient is also going to benefit, and they have tried to follow these type of patients also and tried to see the change in the eGFR. And we know that when we see the decline in the eGFR in patients who are on drugs like dapagliflozin versus a patient who has diabetes, there is definitely a benefit with the use of dapagliflozin, and the similar thing was seen that the change in the eGFR over time was lesser with dapagliflozin as compared to a patient who was not given the benefit. And one more very important thing is the UACR, because we know that proteinuria, if it is not treated, can lead to further decline in the eGFR, and then they have again tried to see that dapagliflozin did have a benefit, and we all have been using it in our patients for this indication for a very long time now. And also the similar thing, they have found that the newer users of the dapagliflozin had a lower rate of confirmed new onset CKD. So that's what I was talking about, that today you may have a patient who is not having the high risk factors today, may not be having the renal failure today, but this patient, if you give this drug, may benefit in the long run, and it may give a benefit in the progression of the CKD in this patient. So we know that they found this, that the newer users, those who were put on dapagliflozin, their newer onset CKD rate was much lesser. Also, this is another thing, because as I told you that initially we were like skeptical, okay, it will work only till 60, then we said no till 45, then it came down to 30, and then 20 it came down, and now we are talking about hemodialysis and peritoneal dialysis patients, where this was one of the prospective single center open label trial. They only took 7 patients because we know that it's not safe to try all the patients the drug which has not been approved, so they did only 7 patients. And they again had a control group of the patients with the eGFR of more than 60. They gave 10 mg of dapagliflozin, and they tried to see the dialysate, and they tried to see the samples after the ingestion. So they did not find much change in the blood levels or the pharmacokinetics of the drug after the dialysis. Also, the patients who were put on dapagliflozin, not only it improved the kidney functions, it also had a good effect on the cardiovascular outcome that we all know. And also they assessed the effect on the anemia. And here if you see, the anemia was present in around 40% of the patients. And you can see here the patients with anemia correction, without anemia, and anemia related adverse events, and you can see the first group it was around 53.3 as compared to 29.4 in placebo group. So that's what, as we are talking about the other pleiotropic benefits, what they have seen. So also they have tried to see the use of the SGLT2 inhibitors, and we know that we use it with diuretics, mostly heart failure, CKD, all these patients they are put together, and they are trying to are we trying to reset the renal volume set point. So what they have found is that administration of the SGLT2 inhibitors may actually improve the volume set point for the kidneys, and which allows for the volume excretion in the setting of hypervolemia. So this is another thing which now we have come to know. Now, if you see the cardiovascular trials, we also have found a similar data. Like if you see the heart failure risk reduction, this is a well-established fact. We have data from Dapacare, we have data from multiple other trials coming up that there is a definite benefit in the CV death, all-cause death as well, total heart failure hospitalizations and repeat admissions with heart failure, and the MACE events as well, and CV death or heart failure hospitalizations as well. Now, if you see the patients who had a lower EGFR, now again the same question came, that will it be beneficial? So then again they have found that benefit to risk ratio actually favors dapagliflozin continuation in heart failure patients with EGFR of 25 or less. Because we know that many times, and most of the times, we get these type of patients coming to our OPD and we don't know what exactly to be done. And this is one of the analysis from the pooled data where they have found that patients even with EGFR less than 25, they have found that it was found to be beneficial for that indication. Also, again, they have found that it also reduced CV death in this group of patients, or the worsening of the heart failure also, irrespective of the deterioration in the EGFR to less than 25 ml. And there were no excess increase in the serious adverse events, because the next thing we are concerned about is, are they going to cause more adverse events? So that also didn't happen. Now, if you see, again they have tried to see the effect of the dapagliflozin on hospitalization for heart failure according to the severity of the inpatient treatment course, and this was again the data from the DELIGHT and the DELIVER and the Dapacare, and they again have to see, try to see the complicated heart failure versus the uncomplicated heart failure hospitalizations and the hospital mortality. And again they have found that the treatment with dapagliflozin actually has been found to be beneficial for all these indications. So again we have found a beneficial effect. This is all the analysis from the pooled data. And the other, this is a very interesting study, that is the DAPA-MODA study, where they have tried to see the effect of the dapagliflozin on the cardiac remodeling in patients with chronic heart failure. And this is one of the multi-center studies which is open label, prospective and interventional. And this was, they were trying to see on the effect on the cardiac remodeling in parameters over a period of 6 months. And what they found was that the dapagliflozin administration in the stable outsetting patients with chronic heart failure and optimized therapy actually resulted in a global reverse remodeling of the cardiac structure, including the reduction in the LA volumes and improvement in the left ventricular geometry, and also in the NT-proBNP, because we know that we have to monitor with the NT-proBNP levels, and that's what they found in this study. So this is what was seen, that they tried to see the LAV, they tried to see the left ventricular mass, and they found an improvement. This was the DAPA-MODA study. Again, one more is the DAPA-RESIST trial, where they have tried to compare dapagliflozin versus the metolazone in heart failure resistant to the loop diuretics. We know that many of the patients with heart failure don't respond to loop diuretics, so we need to have options, and we commonly use metolazone for those patients. And they found that it was similarly effective at relieving the congestion when added to the intravenous furosemide. So it was found to be equally effective, and it was well tolerated with a better biochemical profile actually. And also we know that we are always worried about potassium, we are worried about the serum creatinine rise, so that all was better taken care with dapagliflozin in this study. Now, the final indication, what is the main thing we are always worried about, is the MI or the event. And again, they have tried to see the use in myocardial infarction without diabetes or heart failure. So because this is sometimes not our domain, or not, they are not coming to the endocrinologist or the diabetologist, they'll be going directly to the cardiologist. And this was a study which was done, like either they had MI, NSTMI or STEMI within less than 10 days and impaired LV systolic function or Q-wave MI, and they were hemodynamically stable, then only they were included. And the exclusion of the main exclusion criteria, if they had diabetes, they were excluded. So they did not include diabetes patients in this. And the dapagliflozin versus the placebo, the standard of care was given to all. Only the extra thing added was the dapagliflozin. And 4,000 patients, minimum follow-up 3 months, and trial duration 2.5 years. So you can again see the death, the hospitalization with the heart failure, and again they have tried to see the MI, even the AF rates, because that's one of the causes of mortality sometimes, and the weight decrease also that they have tried to see, and they have found that dapagliflozin most of the times in many of the indications, especially the components 1 to 5 you can see, which are the major components which concern the mortality in these patients and also the development of diabetes, also was found to be better with dapagliflozin. So what they concluded that patients who did not have prior diabetes or these patients actually benefited with regards to the improvement in the cardiometabolic outcome. So what we found that the AF rate was less, the hospitalization was less, and again the diabetes was also less. So obviously what we are trying to say is, obviously there are benefits in the form of reduction in the visceral fat. These patients will lose some weight as well, and there are multiple other pleiotropic benefits like reduction in the inflammation, which again translates into reduction in the insulin resistance and reduction in the cardiometabolic risk factors. So some studies, as I told you, will be in the end talking about some of the indications which are not the approved indications, but very soon these indications may come in. So MASL, which we call it now, or NAFL, which we used to call, we know that we have very less options for these patients. We mostly advocate lifestyle modification, weight loss. We do have options with pioglitazone, but we know that we cannot use it for a great lot of patients, especially the older lot, and then the patients especially with heart failure. Then we have options of metformin, again may not be the best suited drug. And then we also have options with some of the other drugs which have come up. We have some thyromimetics which have got approved now. But still we don't have much of the options to offer these patients. So this is one of the area where this drug has been tried and has been found to be useful in some of the studies at the moment. And this was one of the uses of the dapagliflozin in NAFL patients, and they have tried to do this systematic review and meta-analysis, and they did find that there was a reduction in the liver enzymes and betterment of the GGT as well. So what this also, they found that there was a reduction in the triglyceride level as well. So this was one of the new things which we know now, that SGLT2 inhibitors have been tried for this indication as well. And this we have already discussed about, so I'm not going to the detail of it. And this was also one of the studies where they tried to see the differences according to the frailty in patients with heart failure. This was one of the pre-specified analysis of the liver trial, and they found that it was consistent across the different levels of frailty. This is very important because we may think that this is a lean patient will not respond to dapagliflozin or may not benefit from the SGLT2, but that's not what they found in the study, and this was actually a pre-specified analysis. And also, you can see here that they did not find that the patients who were frail did not benefit. So it was not like that more frail benefited more. Also, they have there are some of the things that we know that the risk of the kidney stones is sometimes higher in patients with diabetes. And here they have tried to see the effect of the SGLT2 inhibitors, and they found that the magnitude of the risk reduction which was observed with SGLT2 inhibitors was greater in adults who were less than 70 years than in those who were more than 70. So this is one of the other few beneficial effects which are coming in, and we also know that the SGLT2 inhibitors also cause a reduction in the uric acid levels as well. And again, the question of the stage 4 kidney disease, and they found that it was consistent with the other stages. And this was one of the DAPA-CKD sub-analysis, and the DAPA group had 293 patients and placebo had 331. And they found that amongst the patients with the stage 4 CKD and albuminuria, the effects of dapagliflozin were consistent with those observed in the DAPA-CKD trial overall. So it's not that that group did not fare better as compared to the other patients. So this is one of the very interesting studies which was done in the metabolic parameters in patients with PCOS, because again we know that for PCOS we don't have much of options to offer. We do have, but we don't have much of options, and this was one of the studies where they tried to see whether the hyperandrogenemia and the ovulatory dysfunction, whether there was an improvement, and also in the metabolic parameters. And they have tried to see the change in the body weight, the glucose levels and the insulin resistance, and obviously with the weight loss and with the beneficial effect on the reduction in the inflammation, they did see a benefit in these patients. Again, as we were discussing, the sleep apnea is one of the very, very important things, and they again tried to do a meta-analysis from the different study data, because there was a documentation of this thing in the studies which were done with dapagliflozin. And we know that sleep apnea is one of the very common problems, especially it exacerbates the hypertension, exacerbates the glycemic control, or the glycemic control goes worse, and also the heart failure as well. And it is quite common in patients with heart failure, and they did find a good amount of patients, a good number of patients having the sleep apnea. And they have again tried to see that there was a reduction in the worsening of the heart failure after the reduction of the sleep apnea in these patients. And they have found that there was like beneficial effect again with the use of the SGLT2 inhibitor. So gout, we all know that there is a reduction in the uric acid level with the drug, so that can be one of the other beneficial effect which has been seen, and we have seen very good effect in our patients with gout with the use of this drug. So we know that this is my final slide. So if you see the overall use of the dapagliflozin, we know that it has multiple indications, starting from, yes, type 2, it is an anti-hyperglycemic agent, no controversy on that. But over a period of time, we have learned that it can be used also as a drug for heart failure, solo also, but also in patients with diabetes. If you offer the drug on time and early, it has better nephroprotective effect, has pleiotropic effects, we know inflammation, reduction in the fat, and also has a reduction in the uric acid level. We saw some beneficial effect on the anemia as well. But also along with that, we know that the decline in EGFR is prevented to a great extent, and what happens in a patient with diabetes. And also we know that it has multiple other indications coming up in the form of use in MASL or NAFL. Now we know the terminology has changed. And along with that, with PCOS and sleep apnea as well, especially in patients with heart failure, because that was an added benefit they saw with the use of this drug. So these are the multiple things which we have come to know from the various studies. Thank you.
Thank you very much, ma'am. That was very informative.